السلام عليكم.
وعليكم السلام sir.
How are you guys?
Good, sir.
Fine sir, alhamdulillah.
Alhamdulillah. Today we change the timing. Inshallah, next time it will be the same 4 p.m. UK time. Okay. We will try to make many sessions because we don't have time till the exam. So we can make session tomorrow if you don't have any problem.
No
Yes,
problem, sir. We
no
can do.
Yeah.
Sure, sir, no problem.
Okay. So even this week we can make if daily so we can finish quickly.
Okay, sir.
Yes, sir. Sure.
Yes, sir, much
Yes sir,
needed.
inshallah.
Okay. Because recommended from many doctors, they ask me in private to make many sessions and many mock exams. Okay. So we will continue procedural skills and supervision and teaching. So procedural skills, 2 stations, and supervise and teach 2 stations. So total 4 stations in the exam. The most important domain, management plan, communication skills, your attitude inside the room, and organization should be organized. Inshallah, if we finish procedures and the teaching, we'll go for examination and then communication. Accuracy should mention all the points, I mean the general checklist. Skillfulness, you should be fluent. And supportiveness, you should involve the actor. Rapport, empathy, sympathy, comfortability, pain. Efficiency structure, you should be organized. Safety, good and correct management plan. The general approach of most of procedures, pre, during, and post. So pre means indication, contraindication, complication, how to prevent and treat complication. If you have alternatives, you can mention here, number 5. During, it will be preparation and the procedure. Post, it will be post-procedure management, post-procedure advice and follow-up, and documentation. Regarding preparation, it means prepare yourself, the doctor, prepare the patient, I mean the actor, and prepare the equipment. So 3 points. Okay, we have Nelly, Naveed, Kashif, Rodra, Imran, Muhammad, Yara, Zishan, Afshan, May, Shadi, Shwaria, and Omar. Okay, Nelly,
Good evening, Dr. Hani.
good evening. So regarding traction splint, maybe they will give you the old one or maybe the new one, okay?
Okay.
So we will practice for the old one. Okay, so this is the old one and this is the new one. So the same idea, it will be below the limb and one sling for the pelvis, the hip, and the 2 slings above the knee, 2 slings below the knee, and 1 sling for the ankle. Clear?
Yes.
The same idea. Okay. The most important, you will measure the limb and you will check neurovascular status, the vessels and the nerves, the sensation and the pulse, and you will also do reduction, extension, or okay. Then you will apply. So for the new one, it will be very easy in the exam. Just the bottom below the limb and tie the slings. Will be easy. So here regarding this one, the old one. Okay. So the old one, you will apply Are you familiar with that?
Yes.
Okay, we will see. So here you will find one nurse. You will find one nurse and one patient. So as we mentioned before, if you find one nurse, you will talk with the nurse first. Okay, introduce yourself, then rubber, then ask her to prepare equipment. Easy.
Yes.
After that, you will go to the patient, introduce yourself, ask about the name and the age, and the comfortability, any pain, and rubber, empathy, everything. And then explain to him what you will do. You will apply blah, 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 because you have blah, 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 blah. Okay. Then you will do the procedure according to the steps. Okay. You are not expected to do it properly. No problem. The most important, the steps. Okay.
Okay.
So you have 30 seconds and then 6 minutes. You have nurse and patient. Okay. And
Do I need to take a brief history from the patient? No?
no need. Okay. So tell him about you will apply because you have blah blah blah. So this is the indicator. Sometimes the examiner is annoyed because you will mention indication, contraindication, complication. You know that? Okay. So how to avoid this point? Sometimes the examiner will say apply the traction. He want you to not talk with the patient. So how to avoid this point? For example, instead of saying the indication, blah, 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 no, you can say like that. I need to apply traction splint because you have fracture in the of the femur bone. Clear?
Okay.
Like that. Okay. So what about contraindication? You can say I need to ask you to have any allergy, any blah blah blah, or even you can ask directly any allergy, any past medical disease, any prescribed medication, directly. No need to mention the contraindication. You know that.
Okay.
Regarding complication, you can mention directly. You can say it has some complication like blah blah blah, but we are expert to avoid that. So by this way, I think the examiner will not notice. Okay.
Okay.
So you have 30 seconds and 6 minutes.
Can I start?
Okay, you can start.
Hello, nurse. My name is Dr. Nelly. I'm the AD registrar today. Can I just confirm your name and your level, please?
Yeah, I'm Nadia. I'm junior now.
Nice to meet you, Nurse Nadia. We have a patient with a femur fracture. So that patient needs a femur traction splint, please. Is it okay if you can help me prepare the equipment? Do you know what equipment to prepare? Okay, no problem. I'll tell you the equipment to prepare. So we will need a hip ring, a metal framework, padding for the metal framework, a skin traction set, devices to help with the skin traction, and slings to help stabilize the leg on the metal framework. Is that okay, sister? Can you help me prepare that? All right, thank you so much. So I'll just go to the patient now. Hello, sir. My name is Dr. Nelly. I'm the AD registrar. Can I just confirm your name and your age, please? Okay, nice to meet you, sir. I'm here today because I've been asked to apply this traction to your leg because your x-ray shows that you have a break in your thigh bone. Do you understand? Okay, so for us to help stabilize that fracture in your hip bone and for us to help reduce the pain, we need to apply the traction. This will involve us applying some bandages and using this metal framework to stabilize the leg while you lie down flat. It doesn't really have much complications. The only complications that we expect will be a reaction from the skin traction on your skin. Is that okay? I also need to ask you a few questions too before we can do that. Are you in any pain at the moment?
The nurse gave me painkiller.
All right, thank you so much. Do you have any allergies?
No,
Any medical conditions?
no,
Any medication?
no.
All right, thank you so much, sir. So I'll now just go ahead to apply the instruction. Is that okay with you?
Yes.
Do you have any questions for me before I begin? All right, thank you so much. Okay, next, please, can you please help me stabilize the leg while I apply the padding on the... So before we start, I'd like to measure the metal framework using the normal leg, the length. So measure from the ischial tuberosity to the ankle and add about 6 inches. That's about 15 centimeters more. Before we apply the traction on the skin traction on the leg, I also want to make sure the patient, examine the patient, check out the neurovascular status of the patient, palpate the dorsalis pedis, as well as ask the patient to wiggle. Is it okay if you can wiggle your toes for me, sir? All right, thank you so much. So I'll connect the hip ring to the metal framework. After connecting the hip framework to the metal ring, I'd like to pad it. Thereafter, I'd like to apply the skin traction to the patient while the nurse helps me stabilize and carry out some reduction on the patient's. After connecting the skin traction to the patient's leg, gently put the metal ring, the metal framework and the hip ring under the patient's leg and sling it with slings. So I'll put 1 sling over the hip, 2 slings above the knee, 3 slings below the knee, and 1 sling on the ankle. After application, I would also like to check the neurovascular status again, check the dorsalis pedis pulse, as well as ask the patient to wiggle their toes and check for sensation in the foot. Thank you so much. Are you comfortable now, sir? Do you have any questions for me? All right, thank you. So I'll just make sure the traction is intact by using tongue depressors to further strengthen the traction, the skin traction to the metal framework. Thank you so much.
Okay, so this patient for discharge or for admission or for what?
Okay, so this patient has to go to the orthopedics for admission. So we
Okay,
inform the orthopedics department and admit the patient for further management and advice.
okay, so the patient needs ORIF for fixation. Okay, well done.
Yeah.
So this patient already you should confirm comfortability, free of pain. Well done. So you applied the metal with the frame, hip frame. You connected that. After that, you put the padding on the metal. Okay, then you will go for the limb. You will measure the limb, and also you will apply skin traction. You start from the ankle to the both sides of the leg of the limb, and then you will apply padding also on the skin traction. Then you will insert your time just to finish that. Then you will apply the splint below the limb. Okay, well done. So here you will do traction by tying first, tying the skin traction with the metal frame, and then you will do traction by tying it across. So I think the steps very easy. In the exam, even you are not doing properly, no problem. The most important the steps, okay? But you should
Okay.
do. In the exam, you should do. Don't verbalize only. Clear, Nelly?
Yes.
So how many marks, guys, you will give Nelly?
10, sir.
10, yes, and I'm happy. Okay. So she did very well. She talked with the nurse. She asked her to prepare the equipment. She went to the patient. She checked comfortability, pain, and she examined the patient before and after. So she did the steps. So everything is perfect. Well done. Thank you. Okay. Next one, Naveed.
Yes, sir. Assalamu alaikum.
Alaikum assalam. Okay. So arterial cannulation and central venous cannulation. So both of them the same idea, but for the purpose of the exam, the common station arterial. Okay. Maybe they will mention radial or maybe femoral. Okay. So according to the line mentioned in the scenario, you will use. Clear?
Sir, if I found no line dimension, no specific ones, I will go for a better radial.
You should ask the actor.
Okay.
So, for example, they mentioned here radial artery, right?
Yeah.
Okay. So you can ask the junior doctor, how much do you know so far?
Mhm.
Anything specific you want to know? Okay, today I will teach you, I will set learning objectives for you. Today I will teach you how to insert arterial cannula in the radial artery. Clear? Okay.
Yes, sir.
If they did not mention here, so you can ask him anything specific. If he said nothing specific, so you can choose any artery. It's up to you. Okay. If he said
Okay, sir.
how to insert in the femoral artery, so you have to teach him in the femoral artery. Clear?
Yes, sir. Clear.
Like that. Okay. Anyway, regarding this station, the same indication, contraindication. So you will divide the station into 3 parts. Okay.
Yes, sir. Okay.
Yeah. Okay. So these are the equipment. You will use Seldinger technique. If they
Okay,
ask
sir.
you about direct technique, it means no need for Seldinger. Okay.
Yes, sir. Okay.
So in the end, you will connect the patient after inserting the line. You are not expected to insert, just verbalization. If the examiner asks you to do, if you find the mannequin, if he asks you to do, no problem. You will insert the cannula, okay?
Yes, sir. Okay, sir.
And no blood coming out, okay? Because it's a mannequin, not patient. So
Yes, sir.
it's
Okay.
easy. So you will insert the cannula first and remove the needle, keep the cannula, and you will insert the
Guide wire.
guide wire, okay?
Yes,
After
sir.
that, you will remove the cannula, keep the guide wire inside.
Yes, sir.
After that, you will use the dilator, insert.
Sir, in the radial, before in the session you mentioned, sir, to the radial, no need to use dilator.
I'm not talking about the radial, I'm talking in general now. Okay.
Okay, sir. Sorry, sir.
Yes.
Sorry.
So you will insert the dilator. Okay. After
Yes,
that,
sir.
you use the dilator and the guide wire is still inside. Then
Yes,
you
sir.
insert the catheter, this one. Okay. You will insert
Okay, sir.
the catheter thread on the dilator, the guide wire. You will find the guide wire coming out from this one.
Middle.
Okay.
Yes, sir. Okay.
You will insert the catheter and remove the guide wire. Okay.
Okay,
So
sir.
you will flush normal saline in all. This one, this one, this one. Okay. And
Okay.
you will aspirate blood. So by this way, you are not expected to find the blood because he is mannequin. If radial artery, no need to use dilator. So you can teach him like that. So you can tell him, In general, you can use dilator, but in radial artery, don't use dilators to not rupture the radial artery. Okay, so here regarding this one, Seldinger, after inserting, you will connect it to transducer and automatic flushing system. Okay, you will find in the exam, it will be by the same shape like that. Okay, you
Yes,
will find three bars. One for the cannula, this part, and one for the pressure bag, and the cable. I think the cable will be obvious. You will find the cable and the exit here. It will be obvious. This is the cable for the monitor.
Okay, sir.
Okay, so the nurse maybe ask you how to do zeroing. How to do zeroing. So you will tell her, even if you don't know, just verbalize like that, okay? So
Yes,
you
sir.
will turn on the three-way to the atmosphere. Easy?
Yes, sir. Yeah.
You will
Okay.
turn on the three-way
Atmosphere.
to the atmosphere. Then you will press on the button of 0. Okay?
Okay, sir.
And after that, you will turn the three-way to the patient.
Got it, sir. Yeah.
Yes. This is called zeroing. Means you are setting the blood pressure, invasive blood pressure. You have 30 seconds and 6 minutes. You can start.
Hello, I need to wash my hand and we are PPE. Good morning. My name is Dr. Naveen. I am one of the ED registrar. May I know your name and level, please? Nice to meet you. I believe you have something to discuss with me here. Is it right today? Regarding arterial, how to insert the arterial cannula? Okay, really, it's a very important critical skill in the emergency, and we are doing the daily this one. So, how much do you know so far about the arterial cannulation? Anything specific you want to learn? Okay. So, what about the patient is stable? Any doctor care for the patient? So let us today, I will share the learning objective for you. And today I will teach you the indication, the contraindication, the complication, the alternative, and how to avoid and treat the complication, and the procedure itself, the equipment in the use in the procedure, and the post-procedure management advice, post-procedure documentation, and advice to the patient. And at the end, I will give you good videos and website, and I will teach you more. So next today, I will teach you arterial cannulation for Seldinger technique, and next time I will teach you direct cannulation technique for the arterial artery insertion. Please listen to me, follow me. If you have any question, please free to ask me. Sister, please prepare for me the arterial cannula kit, and please check the catheter is working or not. Okay. So did you understand me? Did you follow me? Okay. So what is the indication for arterial cannulation? That is for two purposes: for monitoring the invasive blood pressure, continuous monitoring, and for diagnostic purpose to get the sample frequently for the blood gases. And the contraindication for arterial cannulation is if there is absent radial pulse, or there is inadequate collateral circulation, or there is you found any full thickness burn over the insertion site. And the complication would be maybe bleeding, maybe hematoma, maybe embolism, and maybe sometime AV fistula. And the most common site for the arterial cannulation, there is many sites, femoral artery, subpiral artery, but today I will teach you how to do in the radial artery. So before going to the patient, we need now to prepare preparation of ourselves and preparation of the patient and the equipment. The equipment used in this procedure, there is will be syringe, there will be needle, there will be dilator and guide wire and arterial cannulation kit and chlorhexidine and dressing set and suturing set. Okay, did you follow me, sister? Did you understand? Okay. So before we start the procedure, first we will prepare ourselves. We will clean the site with the local chlorhexidine, and we will give local anesthesia, and also we will inform if the patient feel any how to prevent the complication. In this one, we should mention to show to the patient if he develop any local anesthesia toxicity, so we will give the antibiotic emulsion. Okay, sister, did you follow me? So we need to clean ourselves in the area also, and we give local anesthesia first superficially to numb the area, and after that we will do first the Allen test to see there is adequate collateral circulation, and we can go the procedure smoothly. So what is the landmark? Landmark is 2 centimeter to the radial artery pulsation, 2 centimeter lateral. We will go the proximal to the radial striatal passage. So first we will insert the needle into the artery, and once we see there is a blood flow coming up in the cannula, so we will remove the needle, keep the cannula there, and then we will insert the guide wire through the cannula, and once the guide wire inside, so we will remove the needle the cannula also, and we will thread the guide wire through the thread the catheter to the guide wire, and we will remove the wire. And one hand must be always be holding the wire to ensure the wire is not accidentally pushed into the artery. And also important, the arterial cannula then will be connected to the pressurized flushing system, and also we will allow monitoring of the pulse wave for the forum and the blood pressure. And so how we will, this is after the connected to the pressure transducer automatic flushing system. Sister, after the procedure, we will have to connect the transducer after insertion of the catheter. So the patient is lying and the transducer level will be at the same level as the heart. Okay, and also the pressure in the bag will be 300 millimeters. So did you follow me? The important thing, how to make zero wave. Okay, so you will change the 3-way catheter to the air, and you will turn off to the patient, and it will be turned on to the air. After that, you will turn on to the monitor, and you will put the button of the 0, and after pressing the 0 button, after that we will turn off the 3-way. It means we set the blood pressure to 0. And how to confirm the catheter is working by pressure wave monitoring analysis, and we will also send the blood sample for the blood gases. Okay, sister, did you follow me? Did you understand me? Anything you want to ask? Okay, so in the end, I will ask the patient, did he feel comfortable? Okay, and anything you want to know? Anything specific concern? Did you understand what I told you? Okay, so also don't forget to.
Thank you. You're done.
Okay, thank you.
Okay. How many marks, guys, you will give Naveed?
Sorry, I will cut the 2 marks because he has not done the Allen test before this procedure.
I just verbalize only, yes.
You mean Allen test?
Yes, sir.
Okay, so how to avoid the complication? You will do Allen test, aseptic technique, and also the patient should be in lying position. Okay, so more than enough if you will verbalize.
Okay, sir. Thank you.
Okay, I can give you 10 marks.
Thank you, boss. Thank you very much, sir. Thank you. Thank you very much.
So you did very well. Even you are rushing in time, but you are checking understanding. Do you understand? Are you following me? Is that clear? No problem. you practice within 6 minutes. In the exam, it will be 8 minutes. So no worries if you will make your tone slower, okay?
Okay, boss.
So here's the patient for admission. So you can say after you finish, you will dispose all equipment, sharp needles and sharp pen, and other equipment in your box, and you will document everything. You will admit the patient in ICU. Okay, well done.
Thank you very much, sir. Thank you.
The pressure bag, how much?
300, sir.
300, yes. Okay. How to confirm it's inside the artery, as you said. So send for blood gases. Also check the with form pressure and ultrasound guidance since the beginning. Okay,
Yeah, I forgot, sir. Yeah, you are right.
because this how to avoid complication also. Well done, thank you. Next one, Kashif.
Yes, sir.
Okay. So here you will insert the cannula. Okay. You will remove the needle. Okay. After that, sometimes the needle it's white. No need to remove the needle. So you can keep like this one. This one. Okay. So this one, the guide wire can go inside. So no need to remove the needle. Clear, guys?
Yes, sir. Okay.
So this needle in this syringe, and you can insert in the artery, and you will insert the guide wire in this needle. After that, after inserting the guide wire, you can remove the needle. But if you use a small cannula like that, so you have to remove the needle because the guide wire will not go inside the needle. Okay, so you will keep the cannula on. So here you will insert the needle first. After that, you will insert the guide wire. After that, as we mentioned earlier, if you insert the needle, you will insert the guide wire, remove the needle, keep the guide wire, dilator if not radial, if femoral, for example, or if central venous cannulation, it will be the same. So you will use dilator to dilate. You will thread on the guide wire. After dilatation, remove the dilator again and keep the guide wire in the artery or in the vein. Then you will insert the catheter thread on the guide wire. And after inserting, you will find the guide wire coming out from here. So you will insert the catheter more and then remove the guide wire all. Okay. Well done.
Excuse me, sir. If I found only the nurse and mannequin, and in a task you did not mention that I need to perform on the mannequin, so I will ask from the examiner that I need to perform or no?
No, just verbalize. If he wants you to insert, you will insert, no problem. Okay.
Last time, sir, I have this air inspiration station. So there was mannequin and I start to verbalize and she asked me about the landmark.
It's different from examiner to examiner. Sometimes the examiner will accept verbalization. Sometimes he will ask you to do. So it's easy, not like in real practice. In real practice, you have to find the needle inside the artery if arterial cannulation, or inside the vein if venous cannulation. But here, just inserting, even wrong, no problem. Clear?
Okay, sir. Thank you very much.
Yes, and you are not expected to find blood coming out. Just insert and then put the guide wire inside and so on. Just the steps, okay?
Okay, sir. Thank you very much.
Well done. Kashif,
Yes, sir.
this same approach, okay? but different in landmarks. So in radial artery, you have landmarks, you should mention that. In femoral artery, you have landmarks, you should mention that. In central venous cannulation, you have internal jugular vein, you have femoral vein, you have subclavian vein, right?
Yes, sir.
So I will ask you to teach the internal jugular vein, okay?
Okay, sir.
So the most important, the patient, whatever internal jugular or subclavian, the patient should be head down to avoid air embolism, okay? Like that. And here, the head of sternoclavicular, sternocleidomastoid, you have two heads. So two heads, it's making triangle. So it will be 1 centimeter below the head of the triangle, directed towards what?
Ipsilateral nipple.
Yes. Okay. So you should feel the carotid pulse. You should feel because you are inserting in vein. So to not puncture the carotid artery. Okay. So you have to clean, you have to insert in the landmark, and the same approach. You can use ultrasound or not. They, in the exam, they don't care about ultrasound. Clear?
Yes, sir.
And they don't want you to use ultrasound. They want to test your skills about the landmarks, okay? So you can say you can use ultrasound guidance, transverse section, then longitudinal section. More than enough. And you can add, if you don't have ultrasound, you can depend on the landmark. Don't give the examiner or the actor a chance to ask you. Clear?
Yes, sir. Sir, I have one query. We have two heads of sternocleidomastoid at the base, at sternum and the clavicle.
Yes.
And regarding Yanke, so far I know that the internal jugular vein is just below the ear lobule, just anterior to the sternocleidomastoid head,
Again, sorry.
not posterior.
Again.
The internal jugular vein lies just anterior to the sternocleidomastoid, not posterior.
Here you have for internal jugular you have three approaches. Okay,
Yes, sir.
so the preferred one, this one, central. It means this triangle, you are in the center of the triangle. Clear?
Okay, sir. Okay.
You can use this one also in front of the triangle or
Yes,
behind the triangle. Did you get my
okay, sir.
point?
Yes, sir. Noted.
I will check. I put here a slide for this issue, but I will check here. Maybe it is here. Yes, here. Okay. So this one regarding the, can you see the two heads of sternocleidomastoid?
Yes, sir.
This is the medial head, this is the lateral head, right?
Yes, sir.
The vein coming in front of the muscle, anterior to the muscle, then medial to the muscle. Okay. And
Okay, sir.
between the two heads, right?
Yes, sir.
That's why you will insert here. Can you imagine?
Yes, sir. Understood.
Here, the central approach. So if in the center of the triangle, what is called?
It's a central approach.
Yes, if the inside the center of the triangle, so it means central approach. If anterior to the triangle,
It's an anterior
Inferior
approach.
approach.
anterior approach. If posterior to the triangle,
Posterior approach.
clear now?
Okay, sir. Noted. Thank you.
Yeah. So central, it means towards what?
Ipsilateral nipple.
Okay. If anterior towards what?
Ipsilateral nipple.
Also, yes.
Yes.
What about posterior towards what?
Suprasternal notch.
So the anterior or the central towards the ipsilateral nipple. But the posterior, it will be towards the suprasternal notch. Clear now?
Yes, sir.
Okay. So anyway, if you will use inside the triangle, you can say this is the central approach. Okay? You have 30 seconds and 6 minutes.
Can I start?
Okay, you can start.
Good evening. I am Dr. Kashi, Field Registrar. May I confirm your name and level, please? Nice to meet you. I believe that you have something to discuss with me regarding central venous line catheter insertion. It is very important and procedure to learn while working in ED. And can I ask how much do you know so far about the central venous line catheter insertion? Anything specific you want to learn? Okay. I will set learning objectives for you. I will teach you today in indication, contraindication, complication, and how to prevent these complications while inserting central catheter. And I will also explain the preparation for the procedure and technique for the procedure and the post-procedure care and disposition of patient. In the end, I will give you some websites and videos for further learning. And we will continue this learning on daily basis. So far as the indications are concerned, the indications include diagnostic indications for taking blood samples regularly. Therapeutic indications include the delivery of drugs, IV fluids, and the total parenteral nutrition. And for the monitoring purpose, it is also used for the monitoring of central venous pressure and insertion of pulmonary artery catheter. So far as the contraindications are concerned, these include the infection over the site of insertion, difficult landmarks, coagulopathy, and there is a cooperative patient. And the complications include there may be arterial puncture, and there may be neck hematoma, there may be air embolism, pneumothorax or hemothorax, and there may be arrhythmias. And if we go so far down, it can lead to cardiac tamponade, and it can also lead to the local anesthesia toxicity if we don't take care of the local anesthetic dose. And the late complications include the line sepsis and venous thrombosis. And how to prevent these complications, we should use aseptic techniques, and the procedure should be done in the monitored area with the cardiac BP and oxygen saturation monitoring. We can use ultrasound guidance, and local anesthetic dose should be properly calculated. It should not exceed more than 3 milligrams per 3 milligrams per kg, and it should be reduced in extreme of ages. And the common site of insertion include internal jugular vein, subclavian vein, and femoral vein. Is it clear so far? And regarding the preparation is concerned, we initially take the ample history from the patient, history of allergies, history of any medication, any past medical history, and last meals. And after that, we examine the patient chest, neck, and cardiovascular examination. We do X-ray chest before the procedure, and we explain the patient indications, contraindications, complications, and we sign the written consent from the patient. And we prepare the equipments that include gauze piece, povidone iodine, disposable syringe, lignocaine 1%, central venous catheter with dilator, suture, plaster, and dressing pack. Is it clear so far? And then we prepare ourselves, we wash our hand, wear PPE, we start the procedure. The patient is in supine position with 10 to 20 degree, head tilt downward, and neck slightly extended and turn to the opposite side. And we clean the area, drape the area. We inject local anesthesia in the skin and subcutaneous tissue. And then we insert the cannula in the triangle bounded by the two heads of sternocleidomastoid and the clavicle. At the apex of this triangle, we insert the cannula. The angle of cannula is 30 degree, and it is directed towards the ipsilateral nipple. Is it clear so far? And after that, once we see the blood in the hub of the cannula, we remove the needle. We pass the guide wire in the cannula, and over the guide wire we pass. Once guide wire is inside, we remove the cannula and we pass dilator. And after dilator, we remove the dilator and we pass catheter over the guide wire. And when catheter is in place, we remove the guide wire. Is it clear so far? And we press the punctured site with the gauze piece to prevent bleeding. And then we flush the each lumen of catheter with the normal line. And we also secure the catheter with either suture or with plaster. We do X-ray chest to see the position and to rule out iatrogenic pneumothorax. And in the end, we dispose the equipment sharp and sharp bin, and the other equipment in yellow bin. We examine the patient, repeat X-ray chest, and we document the procedure, and we admit the patient in ICU. Is it clear so far? If you have any query, you can ask me. Thank you.
Okay, you still have 30 seconds. Okay, well done. So how many marks, guys, you will give Kashif?
100.
10, sir.
Give him 100 out of 10.
Okay.
15.
So I think he's doing very well. Here, guys, this one will help you in real practice. Try to make an ER. It's very easy. So the medial head of sternocleidomastoid, I think it's obvious in any patient, right? This one.
Yes, sir.
Yes, sir.
So you can use the central approach. This is the preferred approach. Okay, just between the two heads here, 1 centimeter below the apex, and towards the ipsilateral nipple. It's very easy. And if you have any patient shocked, you can try an ER. Even if it's a fail, no worries.
Attempted IO access within the previous 48 hours in the target limb, infection, trauma, and burns at or around the insertion site.
Okay. So here the same approach of arterial cannulation. So the most important here infection in any cannulation, whatever artery or vein. So you will use ultrasound if not applicable or not available. No problem. You can depend on the landmark. So you will clean. The patient is patient head down. You will clean, and the head is turned to the other side, and then you will cover, expose the landmarks. Okay, so this is the medial head or lateral head of the sternocleidomastoid?
Medial head.
Medial
sir.
head.
Medial head. So you will insert here, okay, towards the ipsilateral. So if you want to insert from this side, from this point, what is the approach?
Anterior
Anterior
approach, sir.
approach.
Anterior approach.
Okay. And if you want to insert from here,
Posterior
Posterior
approach.
approach, sir.
clear now?
Yes, sir.
Yes, sir. Thank you very much.
Yes. So this one central or this one anterior, it will be towards
Ipsilateral nipple.
how many degree? 30 or 45? This one, it will be towards what?
Suprasternal
Towards the suprasternal notch.
Western language, okay? So once you will insert, you will find it's already in the vein. But here in the central, you have to put 3 fingers here. 3 fingers parallel to the medial head. Easy?
Yes.
Yes, sir.
You put 3 fingers here. 1, 2, 3. And feel the carotid artery here. So once you feel the carotid artery, be sure that you are away from the carotid artery. Clear now?
Yes, sir.
Yes.
Yes, sir.
Very easy. You can try in ER, you will not lose anything. course, after inserting, you have to fix and the same. You will check for blood gases. You will connect it to pressure transducer and pressure bag. So the same idea of arterial cannulation. But here you will check for central venous pressure with the other one. You will check for central arterial pressure with okay. Next one, Rudra.
Yes, sir. Good evening.
Good evening. So intraosseous needle insertion. It's not common, like arterial cannulation. So here you want to use the indications, contraindication, complication. Maybe you will find the one with gun or battery, okay? Or maybe
Yes,
you
sir.
find the manual one, okay? Same idea. You will insert in the landmark. You should mention the landmark. So you should divide the station into 3 parts: before, during, and after, right?
Yes, sir.
Are you familiar with the station?
Yes, sir. I can try, sir.
Okay. So you have 30 seconds and 6 minutes.
Okay. Can I start, sir?
Okay, you can start.
Good morning, Dr. Rudra, one of the registrar. Can I confirm your name and grade, please? Nice to meet you. So I believe you have something to discuss me regarding intraosseous needle insertion. Yes, great. It's a important skill to have. So how much do you know so far? Okay. Anything specific you want to learn? Okay. I believe you have a patient. So let's go to the patient. Okay. Good evening, sir. I'm Dr. Rudra. May I know your name and grade, please?
Lubation, mannequin.
Okay. 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 So I will set the learning objectives for today. I will teach you the indications, contraindications, complications, how to prevent complications, and then I will let you know the preparation and the steps of the insertion, and after that the post uh, procedure care and management. So the indication for intraosseous needle is for in patients whom we are not able to get an IV access and you need an immediate access. So intraosseous access is immediate access, uh, and the contraindications. It could be if there is an infection in the site, if there's any fractures of the particular bone, and any coagulopathy, and any complications. We can introduce infection. We can cause iatrogenic fractures, and it can also lead to extravasation of the fluid. So we prevent the complication by doing following an aseptic procedure, and make sure we do it in the correct landmarks, so we can prevent the complication. So for the preparation, we prepare the equipment. We have a battery operated driver. We have 2 catheters, one for adult, one for pediatric. Then we have the syringe, the IV tubing, and then followed by a sterile dressing. So we prepare the patient. Uh, Sometimes we can do it in a conscious patient or in a unconscious patient. If you're doing in a conscious patient, we also give lidocaine. So we clean the site with iodine and then put the sterile drape. We fix the catheter over the driver and we push. This insertion site would be the most common is the uh, tibial side, which is 2 centimeters below the tibial tuberosity on the medial side. So we drive it until we feel a give, and then we remove the driver, we put the cannula, remove the needle, and then connect the IV tubing and withdraw blood. If there's a blood coming out of the tube, that's a confirmation that we're in the access, and then we put a sterile draping over it. So we give the lidocaine 2%, 2 minutes over 2 times, and we can collect samples for most of the values of the endogenous needle, the hemoglobin, the normal electrolytes, which will be almost the same as a venous sample. So we can give fluids, we can give all the medications, even blood transfusion through this access. So post procedure, we make sure it is secured, and it is a temporary access. So it will be if we get a permanent access for an IV access, so that we can remove this, and we can only use it for 24 hours.
So
So
what is the correlation between IO sample and venous sample or blood
so
gas?
for yes, good question. So for most of the samples like hemoglobin, chloride, sodium, uh, so they almost they give the same values as the venous sample. For example, also blood urea, the glucose, calcium, and creatinine. So these are statistically same. Only is the difference is the white plus counts a little bit higher, and the blood gases they vary between the arterial and the venous sample. So that will be the difference. And we always label the tubing with an mark that it's an IO sample to make sure we don't lose it. So these are the steps of introducing an IO access, and it's really important to know, especially in case of emergencies when you have a cardiac arrest and you don't
So
get an
how long we can keep the IO access?
yes. So it's as I said, it's a temporary access. We can only keep it for the maximum 24 hours.
Okay.
Yes.
Okay.
So is there anything else you have any doubts? Anything else you want to ask?
Thank you. Your time done.
Okay. Thank you, sir.
Okay. How many marks, guys, you will give Rudra?
Again 10.
Yes, again 10, of course. So accuracy, almost to mention all the points. Regarding supportiveness, is not rushing in time. He's checking understanding. He's pausing. He's giving information in pieces. And regarding skillfulness, he's very fluent. Regarding what else? Safety, he mentioned all the points. He asked for questions. Maybe I have questions. You should ask or invite questions for the actors. Okay, this is very, very important to give you marks because the Royal College, they have questions. If you answer these questions, you will get marks. Okay, well done. So I
Thank you, sir.
can give you 10 and I'm happy also. Okay,
Thank you,
thank
sir.
you, Rudra. Amran, Muhammad Amran,
Yes, sir.
how are you?
Alhamdulillah, fine, sir.
Okay, this station very common and very important. Okay, urethral catheter insertion. So it's very easy. The most important, you emphasize on aseptic technique and the preparation. You will divide the station into 3 parts also, before, during, and after, right?
Yes, sir.
Okay. Check the expiration. In all procedures, guys, check expiration. All procedures, not only catheterization. For example, arterial cannulation, you should check expiration. Okay. So this urethral catheter, the most important, you should understand you have two-way and three-way. The two, you have color part, and the three, you have also color part. So the color part for what, guys?
For urine,
To know the size.
For
Inflate the bulb.
inflate the
Balloon.
balloon.
Inflate the
Sorry,
bulb.
sorry, inflate the balloon.
Okay. So the colored one is straight or it's like branch?
Branch, sir.
Branch. The main branch is this one, right?
Yes, sir.
And this one is the main branch. So the main branch you can aspirate, okay? Or I mean drain. But the color one to inflate the balloon, like this one, clear?
Yes, sir.
And the third one, it's only in three-way. For what?
Irrigation of
For the
water.
irrigation.
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 Easy?
Yes.
Okay. So the one straight, it's the main one. Okay. This one the straight, the middle. Okay. So any branch, so different option, different function. Okay. So if you have two-way in the exam, you can discuss about this one. If you have three-way, discuss. If you have both, explain both. Clear?
Yes, sir.
Okay. Again, the main one for what?
For
Urine.
drainage.
Drainage urine. Okay, so this one for drainage urine, this one for drainage urine. The one straight. Then the color for what?
For the balloon dilatation.
Balloon. Okay. Because the color in two-way and three-way, it means for balloon, right?
Yes, sir.
The third one, the branch, it's for
For the
irrigation. So
irrigation. Yes.
the one drainage, it's out. The one irrigation, it's in. Clear?
Yes, sir.
So you will insert fluid to the bladder. But this one to drain urine from the bladder. Clear?
Yes, sir.
Okay. So anyway, you have to be familiar with the indications, contraindication, complication, and the procedure itself. You have to prepare equipment, mention the equipment, and then you will do the steps. So the most important here, aseptic technique. So you will
Yes, sir.
wash hands, wear two gloves. Wear two gloves. So you will clean. Okay. After that, after cleaning, you will remove one glove and you still have the second glove clean. Okay. You have another approach. You will wash hands and wear one gloves, one pair of gloves only, and you will remove after cleaning, and then wash your hands again and wear another gloves. It's up to you. Okay. So after cleaning, you will put expose only the genital areas. So you will cover down and above, and you will put a kidney shape. You will insert lidocaine gel anesthesia. Why? Lubricant, number one. Number two, anesthetic, so he will not feel pain. Number three, you will test obstruction. So if nothing going inside the urethra means obstructed, right? Okay. Then you will insert the cassette, the polycatheter. So when you remove, you will remove now or from the beginning, guys. What do you think? You will
From the
open
beginning.
the outer plastic now after cleaning or from the beginning?
Now.
At the end.
No.
At the end.
Cleaning.
Now,
After
After
cleaning at the
cleaning.
end.
after cleaning, sir.
how you will cut after cleaning your hand already. What do you think?
So
Sir, we
There
will
is
remove
there
from
is
beginning, but we will just
some
remove the tip
staff will be
out of
there.
it.
Okay, so anyway, you cleaned already. So even if you will touch this part, you will touch the plastic, not the catheter itself, right?
Mm.
Yes, yes.
So you should cut after cleaning. Okay.
Okay, okay.
The most important, check the expiration date.
Mm-hmm.
So you will cut the tip only of the plastic, and you don't touch the catheter.
Catheter tape.
Yes.
Yeah.
So you will insert the tip, okay, with holding the penis, and then insert the part and hold by the other hand, and so on until you reach to the end.
Bladder.
Yes, until you reach the end. This is the end. I want you to insert all, okay? After that, you will inflate the balloon. Inflate which one?
The
Colored
colored
one.
part.
The colored
Colored
one.
one.
The colored one, to understand this is for balloon, okay? Why you will insert all like that? To be sure the balloon is in the bladder. So if the balloon in the urethra, you will rupture the urethra, you will rupture the penis, right? Okay.
Mm-hmm.
So you have to insert all to be sure that all the catheter inside the bladder. Clear?
Yes, sir.
Okay. After inflating the balloon, then you will pull again. Pull until you find the resistance. You will pull, remove the catheter from the urethra until you find the resistance. So when you are removing, gentle removal, okay? Like that. Can you see?
Yes, sir.
Okay. So when you are inserting, you will insert all. When you inflate the balloon, remove all. Easy?
Easy.
So the balloon will be um,
On the
what?
neck of the bladder, trigone area.
Yes, excellent. Okay. So why I will insert all to be sure that the balloon inside the bladder, not inside the urethra, right?
Yes, sir.
Why I will pull all the catheter? To be sure that
Prevent leakage.
no, to be sure that the holes inside the catheter not touching the wall of the bladder, because if it's touching, it will bleed the wall. Clear?
Mm-hmm.
And it will
Mm-hmm.
stuck. It will be obstructed also. Okay. Also, the bladder here, because of gravity, the urine will be down, right?
Mm-hmm.
So if the balloon is up, do you think it will drain urine?
No,
That's why better to be down. Easy?
easy.
Yes. Anyway, this information not important for the procedure. The most important, as we mentioned, clean and the expiration date of equipment. Okay. You have 30 seconds and 6 minutes.
Hello, good morning. I am Dr. Azim Imran. May I confirm your name and level, please? Nice to meet you. I believe that you are here to discuss something with me. Okay. How do you know so far about the urethral catheterization? Anything specific you want to learn about the urethral catheterization? Really, I really appreciate your interest. This is a routine procedure we do in the emergency department. I will teach you today regarding the urethral catheterization. I will set the learning objectives of the urethral catheterization into the different parts. I will teach you indication, contraindication, complications, how to prevent and treat the complications. Then I will let you know the technique of the urethral catheterization, and after that I will provide you the resources and the video links for your future learning. Now, first of all, the indications. We pass the urethral catheter for for leaving the urinary retention, as well as to monitor the urine output. Moreover, we pass the urethral catheter to facilitate the bladder irrigation. Are you with me? If any point you feel difficulty in taking it and unclear, kindly let me know. As far as the contraindication is concerned, we don't pass the urethral catheter if there is a urethral trauma or there is a acute prostatitis. Are you with me? Regarding the complication of urethral catheter, there is infection, there is a urethral trauma, as well as there is a failure of the procedures. So, for the technique, I will go to the patient, I will take the consent of the patient and explain the procedure to the patient, and I will divide the procedure into the three different parts, that is the pre-procedure talk, and during the procedure what is the procedure, and after the post-procedural advice. For the pre-procedure, I will do the let the prepare the equipment for my catheterization, for which I need the normal saline solution, and I will need the sterile syringe and the tampons. I need the disinfectant for genital cleaning. I need the disposable pads, disposable gloves, sterile gloves, urine catheter collection bag, and the kidney dishes, and the Foley catheter along with the bag as well. So, as far as the I will prepare myself as well as I prepare the patient. For the myself, I need to wash my hands and wear double gloves. So I will put the two gloves. And for the preparation of the patient, I will clean the area with the pyodine, and I will put the drapes beneath the patient, as well as I will expose the genitalia only. Then I will regarding the position of the patient should be in the spine position. So now I will teach you the technique. Are you with me? Is anything ambiguous? Kindly let me know. So regarding the technique, first of all, we do this procedure in the privacy along with the chaperone, because the privacy is very much concerned in this procedure. First of all, I will do the clean the area and the clean the genitalia with the pyridine, and the special technique for this is we hold the penis with the gauze with the non-dominant hand, and then we clean the glands and from the up to downward, so that and then discard the swabs. And after that, we put off the one gloves and remain the other glove, our other gloves. Then we will hold then we hold the penis with our non-dominant hand, and place the kidney tray below the private parts, and then we hold the when I will inject the local anesthesia, that is the xylocaine gel with a pre-filled in the disposable syringe, and inject into the penis so that the penis get numb. And then I will take the open the catheter wrapper, and ensuring that I will not touch the catheter tip, and I will do the aseptic measures while passing the urinary catheter. Then I will hold the penis with the non-dominant hand along with the gauze piece, and insert the catheter gently into the urethra, and I will insert the catheter fully into the urethra, so that I make sure that it will not remain inside the urethra. It will goes into the bladder. Then I will inflate the balloon with the water-filled syringe and make sure that it will not cause any pain to the patient. Then I will withdraw the catheter so that I feel the resistance, and this is the exact point which we need in this catheterization procedure. Then I will connect the catheter with the urinary bag and will place below the patient. Then I recover the patient and dispose of the all my equipments accordingly. Then I will monitor the patient. Either there is the color of the
Oh,
urine,
doctor,
either
so
there is.
what if the patient has bleeding?
Yes, if the patient has bleeding, it means I will remove the catheter at the meantime, because it may point us that there is a urethral trauma, or if there is a sudden decompression of the urinary bladder, it also cause the blood in the urinary bag, leads to the and in meantime for
Okay, thank
after
you. Your
this.
time done. Thank you. Okay. We are practicing within 6 minutes, so you don't have problem in the time management because in the exam 8 minutes, as we mentioned that before. Okay. Thank you. How many marks, guys, you will give Matt?
10 out of 10.
Okay.
10, sir. 10.
Okay. Well done. His accuracy almost mentioned all the points regarding skillfulness. He's fluent. I feel he will sleep.
Yes, it is too much late, sir, today.
Okay. So in the exam, adrenaline will work with all people, and so
Yes.
you will be alert. Anyway, regarding skillfulness, you are fluent. Supportiveness, you are explaining in simple way. Also, pausing, you are not rushing in time, giving information in pieces. Here, if the patient has bleeding, so maybe he has problem before insertion, right?
Yes, sir.
And the bleeding came out, or maybe he has urethral rupture, okay, after insertion. Okay, so what you will do, you will deflate, you will deflate and remove, deflate the balloon and remove the catheter and call the urologist. You mentioned that, but you did not mention call the urologist, right?
Yes, yes.
So what if the patient has resistance? It's not going inside. What will you do?
Then it means we will not do the procedure, and we will call the
Patient in
urologist.
severe pain. So what you will do?
If there is a pain, sir, pardon me.
Pain, the patient has pain, urine retention, pain. And
Yes, for
this is
suprapubic aspiration, and then we do the
no,
suprapubic aspiration. We
don't
do.
do suprapubic. Okay. So give the patient painkiller, don't proceed, and call urologist.
Okay, thank you.
So yes, for example, sometimes I did suprapubic, but it doesn't mean you will do in the exam. For the purpose of the exam, just give the patient painkiller. Because of resistance, you will not insert, and you will call the urologist. Okay. Yes.
Okay.
So of course, you will do ultrasound before and after, right? To see
Yes, sir.
if there is urine inside the bladder or not, the patient has stones or not. Okay, well done, thank you.
Thank you.
Muhammad?
Yes, sir.
Yes. Okay, so the next one, female, so it will be the same, and it's not coming in the exam, so we will skip, okay? It will be the same, so will not waste the time. Okay. Non-touch technique for suturing. So they can give you a mannequin like that. Clear? Clear, Muhammad?
Yes, sir.
Okay. So they will give you nurse and patient and the mannequin on the arm of the patient. Okay. So what you will do, you will talk to the nurse first, right?
Yes, sir.
So you will talk to the nurse. I'm Dr. Blah, blah, blah. May I know your name and the grade? Nice to meet you, Robert. I believe you have one patient for what?
Suturing.
Suturing. Okay. Please prepare all equipment. Thank you. Ignore the nurse. Then you will go to the patient. Okay. Sometimes the examiner is annoyed because of indication, contraindication, complication. So no need to mention by this way. Okay. So you can talk with the patient. I'm Dr. Blah, 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 one of the ED senior. May I know your name and age? Nice to meet you, Robert. I'm here to do suturing for you. Do you have any pain? Are you comfortable? Okay. So you will talk about indication, but in direct way. So you can say, I'm here to do suturing for you because the wound is
Open.
deep and gapping. Clear?
Deep and deep.
Okay. Contraindication, no need to mention the point of contraindication. You can say about ample history without mentioning the word contraindication. Clear? So you can ask the patient directly, do you have any allergy, any past medical disease, any prescribed medicine, when was the last eat and drink, and what happened? Easy?
Yes, sir.
What happened here? You will understand if the wound is clean or not clean. For example, maybe the patient will say it's in the kitchen or in the farm or anything like that. And of course, past medical disease and the prescribed medicine, you will ask about previous immunization because immunization, it's in the point of prescribed medicine, right?
Yes, sir.
Okay. So after you finish ample, you will go for complication. So we finish the indication, finish the contraindication, then complication. So this procedure, we are dividing into three parts, like any procedure, before, during, and after, right? Okay. So regarding complication, you can say it has some complication like pain, infection, more than enough. No need to mention all the complications. Regarding the pain, we will give you painkiller and we will inject medicine, local anesthesia, to numb the area you will not feel. And we will clean for infection. Easy?
Easy, sir.
Okay. Then you will jump to the during. During here, you will talk to the nurse again. Did you prepare all equipment? Yes. Then you will wear gloves. In this station, especially this station, you will wear gloves. And you will just verbalize the equipment. For example, syringe, needle, lidocaine, and intralipid, suture, needle, and the artery or needle holder. Clear now? Okay.
Okay, sir.
Then just pretend. Just pretend. You will just make like that on the wand, even you are not touching the wand. You will just say, I will clean the wound by normal saline inside the wound and outside by iodine. I will inject lidocaine around the wound. Don't inject,
Okay.
just pretend, okay? The only thing you will do, suturing. Clear? The only thing in this station you will do, suturing. Okay, so just pretend you will put your hand like that. You can verbalize. Now I will clean the wound from inside by normal saline, from outside by iodine, and I will infiltrate lidocaine anesthesia around the wound, 5 ml, maximum 3 milligram per kilogram, and then I will wait for how many minutes, guys? 5 minutes.
20.
Then you will hold the forceps and touch the edges of the wound. In the exam, you should touch and ask the patient, do you feel that? He will say no. Then you can do the sutures. Easy?
Easy, sir.
Okay. So after you finish suturing, you need to do 2 sutures only. Okay. So how to do suturing? You will find the equipment like that. So you will hold the needle, but don't touch by your hand. You can hold the thread by your hand, no problem, but don't touch this one. Why not touching the needle, guys?
Needle stick injury.
Yes, because of the injury. Okay. So after you hold this one, hold from the lateral 2/3. Okay. So this is the wound, and so after we finish, so you will go for sutures. So you need here forceps and also scissor. Scissor will be with nurse, no need to hold. So you will hold like that from the lateral third like that. Okay. You have 2 ways. You can hold one edge like that. You can hold one edge like that by forceps, by the non-dominant hand, and insert the needle from out to in, out to in. Okay. Then you will hold the other edge from in to out, the opposite. It's up to you. Or you can hold the 2 edges and insert the needle from out to out. Clear, guys?
Yes.
So it's up to you. Some doctors they prefer hold the 2 edges by forceps and insert the needle 2 edges together. The most important here 5 centimeter, sorry, 5 millimeter, and here 5 millimeter means half centimeter. Okay,
Okay, sir.
like that. So if you want to insert the needle from out to out, okay. If you want to insert it from out to in and then from in to out, it's okay. For me, it's easy to insert one needle. Okay. The most important, you will tie the thread on the lateral side, like that. You will do 2 sutures only in the exam. Okay. 1, 2. Here, the nurse will be in front of you and the examiner will be away, like 1 meter or 2 meters away from you. The nurse will tell the doctor if you touch the needle or not. Clear?
Clear, sir.
Okay. So after you finish 2 sutures, you can go for post-procedure management. So you will ask the patient about, you can tell him, now I will give you a printed leaflet. I will discharge you. I will give you printed leaflet, and I will give you advice to not wash the wound for 48 hours and keep it dry. You can remove within 7 to 10 days. I will give you whatever antibiotic or tetanus immunization. It depends on the station. If indicated, maybe he will say in the farm, maybe he will say in the kitchen. So it depends on the station. Okay. Then give him advice about signs of um, infection. Number one, pain. Number two, bleeding. Number three, pus. And the number four, um, open wound. If the wound is opened, it means it's infection. Okay. Clear?
Clear, sir.
Yes. So you have 30 seconds and 6 minutes. Okay.
Should I start, sir?
It's up to you. You can start.
Okay. Okay. Hello, my name is Dr. Tahir. I am the ID registrar.
Raise your
I
voice,
have been
please.
informed that you. Hello, I'm audible, sir.
Raise your voice.
Hello, I'm audible, sir.
Yes.
Hello, my name is Dr. Tahir. I am the ID registrar. I have been informed that you have the patient who needs the suturing. Is it right? Okay. Please, staff, prepare the suturing material and suture and the suture tray, as well as the. Now I will go to the patient. Hello, my name is Dr. Tahir. I am the ID registrar. May I know your name and age, please? Okay, nice to meet you. Um, I have been informed that you have a open wound in your wrist. Is it okay? Okay. So I have to suture that wound because it can, if I don't suture that wound, it can lead to infection. To do the suturing, I need to take some data from you. Is it all right? Okay. Do you have any allergy? Do you have any past medical illness? Okay. Are you on prescribed medication? Okay. What is your last meal? And what is the incident? How this happened?
Yeah, I was in the farm and I injured my arm.
Oh, I'm really sorry to hear about that. Are you comfortable?
Yes.
Okay. I have told you already that I need to suture that wound, but I can see there is no devitalized tissue around this, so I can suture that. And but there is some complications regarding this suturing because you may have pain or you may have infection. So to avoid these complications, we will do it in the aseptic technique, and I will also give you the local anesthesia to keep you pain free during the whole procedure. Is it all right? Okay. So I will wear the gloves and I will be on the side of the patient. I will uh, confirm the site, and then I will uh, paint and drip the wound area, and I will wash the wound area with the normal saline and the peripheries with the iodine. Then I will inject the local anesthesia 3 milligram per kg, and then I will wait for the 5 minutes. Now I'm touching the area. Can you feel this?
No.
Okay, that's very good. So it means you have I have numbed this area. So now I am going to suture this wound. So now I will hold the needle holder, and with the needle holder I will hold the suture needle at the lateral 2/3, and I will go for the suturing. I will lift the edge of the wound with the forceps in my non-dominant hand, and the needle hold in my dominant hand. And after that, I will go from 0.5 centimeter away from the edge, from outside inside. Then from the other edge, I will go from the inside to the outside, and after that I will close that. I will make the knot. After 2 to 3 knots, I will ask the nurse to please cut this from 2 centimeter above the suture. Now I will again holding the needle with the forceps and adjusting my position lateral to third at the needle, and again suturing it second. And after suturing, I can see there is a close approximation of the edges. So after that, I will apply the dressing and make sure that patient is comfortable and he is not in pain. I will check the vital signs, and I will advise the patient that you may after you may keep this area clean and dry for the 48 hours. And if you feel any pain or any redness or any pus from it, or if there is open wound, so you may come back to the ED as soon as possible. And after that, I will document my um, procedure, and I will dispose of the PPE and sharp equipments.
Thank you, your
Do you have
time.
any question? Okay, thank you.
Okay. How many marks, guys, you will give Muhammad?
10, sir.
Okay. Did you talk about signs of infection?
Yes, at the end.
Okay. Did you cover the immunization status? Did you ask about
No,
previous immunization?
no.
So why 10? Okay.
Yes.
Regarding the printed leaflet, so you will give this patient antibiotic or not? You will give tetanus immunization or not? So you should ask about immunization status, right?
Yes, sir, I forgot.
Yes. Okay. So it's very important here in this station. Okay. So in ample history, you will ask about previous immunization in prescribed medicine. Clear? So you will ask any prescribed medicine? No. What about your immunization? Did you receive tetanus immunization before? If yes or no, so it will help you in the management. Okay. So I will give you 8 marks, okay? The most important this station, suturing. If you will not make suturing in this station, maximum 2 or 3 marks. Clear? Even if you will talk about everything. Clear, guys, this point?
Yes, sir.
So take care. You have to do suturing
Yes, sir.
in this stage. Okay, well done. Next one, Yara.
Yes, sir.
Yes. So, okay. Uh, okay. Nerve block. So nerve block here, we have for the face. Face here, we are talking about trigeminal. We are talking about ophthalmic, maxillary, mandibular. Okay. In the face, in the upper limb, in the lower limb, and all the body, like for example, the patient has a wound, you will infiltrate around the wound, right? Or abscess, you will infiltrate around the abscess. It's called what?
Regional block.
Field block.
Field block.
Region field block.
Field block, okay. So in the face, you will use which anesthesia?
Lidocaine.
Lidocaine.
Lidocaine. In the upper limb, in Behr's block, Bryllocaine.
Lidocaine.
Bryllocaine.
BP again. Prilocaine, yes.
In wrist or in ankle, you will use lidocaine.
Lidocaine, yes.
But in fascia iliaca nerve block or femoral nerve block, you will use
Bupivacaine.
Levobupivacaine.
bupivacaine. Ankle nerve block, you will use lidocaine. Clear?
Lidocaine.
Okay. In field block, you will use
Lidocaine.
Lidocaine.
okay. So I think now it's clear. Okay. Regarding the approach of the station, say, okay, you will divide the station into
Three
Three
parts.
parts.
three parts. Before,
During and after.
yes, before, during, and after. Excellent. You will follow the general approach of
Procedure.
Teaching.
teaching.
Okay.
Teaching.
Teaching.
Okay. You will teach what?
The procedure itself,
Procedure.
what we're supposed to do. Okay.
You will teach procedure. Okay.
Okay.
I'm Dr. blah blah blah, one of the AD senior. May I know your name and degree? Nice to meet you. I believe you have something to discuss with me regarding
Nerve
Nerve
blocks.
block.
blood. Nice topic. How much do you know so far about this topic? The first question. The second question.
Okay.
Anything specific you want to know? Okay. I will set learning objectives for you. I will teach you today whatever, supraorbital or supratrochlear, it depends on the station. I will teach you
Okay.
the indication, contraindication, complication, how to avoid and treat complication, the procedure itself, preparation, the procedure itself, and post-procedure management advice and documentation. Is that okay with you? Yes. Easy?
Okay. Yeah.
So the indication for all, numb the area. What is the indication for any nerve block?
Numbing an area.
Numb the area. Which area?
Okay.
In supraorbital, which area?
Forehead. Forehead.
Supraorbital, which area?
Forehead and upper eyelid.
After forehead.
Upper eyelid, upper conjunctiva.
So to numb the area, ipsilateral to the midline. Okay, ipsilateral.
Okay.
It will be from the upper eyelid to the scalp, right?
Okay. Yes.
Okay. Then what about supratrochlear? To numb the area, which
Central.
area?
From the
Lateral,
forehead, ipsilateral.
forehead, ipsilateral, lateral to the midline. Okay. Regarding infraorbital,
Below the eyelid,
Cheekbone.
ipsilateral to the midline.
numb the area in the cheek, below the lower eyelid, above the upper lip, lateral to the nose, or lateral to the midline. Okay. What about mental?
The chin lateral to the
Numb is the
midline.
area. Numb is the area. Which area? Chin. Where? Ipsilateral. Lateral
Okay.
to the midline. Below
Okay.
the lower
Okay.
lip and to the chin. Okay. So here, dental nerve block. What does it mean, dental?
Teeth.
Tooth extraction.
Inferior
Inferior
alveolar
alveolar.
nerve.
Inferior alveolar. Inferior alveolar. So inferior alveolar coming from
Mandibular.
mandibular coming from
Trigeminal nerve.
Trigeminal.
so mental coming from
Inferior
Inferior
alveolar.
alveolar.
so this one distal or proximal?
Distal is the mental
Distal.
nerve.
Distal. If you will block mental, inferior alveolar affected or not affected?
Not affected.
Not affected.
Not affected.
So here mandibular is coming from here, right? Trigeminal here, coming to mandibular. And going inside the mouse, what is called inside the mouse?
Inferior
Inferior
alveolar nerve.
Inferior alveolar. And then coming out
mental nerve.
mental nerve. So if you will block mental nerve, you will block only this area. This area normal, right?
Yes, sir.
But if you block the mandibular, it will block all the mandible
Entire area.
and the inside the mouth and the chin also, right?
Yes.
If you will numb inside the mouth, if you will numb inside the mouth here, can you see inferior alveolar?
Yes.
This one inferior alveolar. If you will go inside the mouth and numb this one, it means you will numb all this area, right? Yes.
Yes.
That's why when we are fixing our teeth, if they will numb inside the mouth, you are numbing inferior alveolar. This one going inside the mandible and coming out from the mandible. Which nerve?
Mental.
Mental nerve.
Easy?
Yes.
Yes.
Okay. So here, trigeminal, as you see, if you block trigeminal, you will block what?
The entire face.
Entire face.
Half of the face, right? Left side or right side, it depends on the side you are blocking. So if you block the trigeminal here, you will block ophthalmic, you will block maxillary, you will block mandibular, right?
Yes.
Okay. So if you inject lidocaine in this area here, you will block all the face, ipsilateral. Easy?
Yes, sir.
Yes, sir.
Okay. So here the ophthalmic, right?
Yes, sir.
This one
Maxillary.
maxillary. This
Maxillary
one
nerve. This is mandibular.
mandibular. Okay. Can you see ophthalmic giving
Yes.
blue?
Supraorbital and supratrochlear.
Supraorbital.
Supraorbital and
Supratrochlear.
Supratrochlear.
maxillary giving branch to
Inferior.
Infraorbital.
infraorbital. Okay.
Infraorbital.
Yes, infraorbital. And also the upper teeth, right? Okay.
Yes.
And then mandibular giving branch to
Inferior alveolar.
Mental.
and the inferior alveolar giving branch to
Mental nerve.
Mental.
I think easy now.
Yes, sir.
Okay.
Yes, sir.
So regarding Bears block, how you will do that? You will put cuff, double cuff, okay, and then you will inject it in the vein, right?
Yes.
Yes.
Rest, you will inject around the wrist, okay? Hematoma block, you will
Into the
where?
hematoma. Fracture hematoma.
Directly to
inside the fracture.
Yeah.
Between the two ends of the fracture. Okay? Digital. you will insert where?
Around the base of your
Into
foot.
the
In
on the sides of the digit.
Yes, on the sides of the proximal part of the digit. Digit, I mean in the fingers or toes, right?
Yes, sir.
Okay. Fascial iliac nerve block or femoral nerve block, you will insert where?
Facial laca at the junction of the lateral.
Triangle.
Yes, it will be below the inguinal ligament. It will be, you will put towards,
Medial 2/3 and lateral 1/3.
yes, fascia lata and the fascia iliac. Okay. Ankle nerve block, you will inject around
Around the ankle.
the
Triangle.
Ankle.
Okay. Field block abscess, you will infiltrate around
Around the abscess.
the abscess
Around the abscess.
by all direction. Easy.
Easy, sir.
Wound infiltration, you will infiltrate around the wound, right?
Around the wound.
So
Yes.
now we know the technique. Okay. So the indication, supraorbital to numb the area and the forehead, ipsilateral, lateral to the mid,
Yes.
to the scalp. Supratrochlear to numb the area, ipsilateral, lateral to midline. Infraorbital,
The cheek lateral to the midline, ipsilateral
Lower
side.
eyelid
numb the
to
area
the
first.
upper lip.
Numb the
Okay,
area.
numb the area.
Cheek below the lower lip.
Yes, in the cheek, below the lower eyelid and above the upper lip. Okay. Mental, numb the
The
area.
chin
In
is
the chin,
bilateral.
In
Uh,
ipsilateral,
lateral,
numb
lateral
the
to midline.
area.
lateral to midline. Dental,
Dental
numb the area.
Superior,
Numb the area.
numb the area.
Which area?
All the jaw
Inside the mouth.
inside the mouth.
Inside the mouth. Okay. Because you want to do procedure inside the mouth.
Yes, sir.
Okay. Ipsilateral or contralateral?
Ipsilateral, sir.
Ipsilateral.
Bird's block.
entire.
What is the indication?
Bird's block,
Numb
full
the area.
forearm,
Wrist
and hand.
Numb,
Area.
numb the area. Which area?
Wrist
forearm,
and hand.
The limb. The limb.
limb, yes.
All the limb below or above the cuff?
Below the cuff.
Below the cuff.
Easy?
Below the cuff.
Easy?
Yes, sir.
Yes.
Wrist. What is the indication?
It is a Colles fracture or
Numb the area. Numb the area. Which area?
wrist.
Hand.
Wrist. Why? To do any invasive procedure. So here to numb the area in supraorbital or supratrochlear or to numb the area. Which area? Mention the area. Why? To do any invasive procedure. Like what? Suture or any invasive procedure. Clear?
Yes, sir.
Yes, sir.
Here in Bears block to numb the area. Which area? The limb. Below the cuff to do reduction. Clear? Rest.
Yes, sir.
To
Yes.
numb the area. Which area? The rest. Okay. To do any invasive procedure like sutures, like abscess, like any surgery in the hand, right? Hematoma block.
Yes.
To numb the area. Which area?
Fracture site.
Fracture
The
site.
fracture site itself.
To do reduction.
Reduction.
Digital nerve block. What is the indication?
To numb the digit.
To numb the area. Which area? The digit. To any invasive procedure like sutures or drain abscess or removal foreign body. Fascia iliac nerve block or femoral nerve block.
Facial echo for the fracture of the shaft of the
femur.
femur, and the femoral nerve block for
Numb the area first. Numb the area first. Okay? I mentioned many times numb the area, and you are
Okay.
insisting. So number one, to numb the area. Which area?
The fracture
limb.
femur,
The limb.
the limb.
The limb. Okay.
The
Which part? Anterior medial. Okay. Anterior medial of the side. Easy?
Easy.
Yes, sir.
Ankle. What is the indication?
Numb the area.
Numb the area. Which area?
The ankle.
ankle, to do
Any
Invasive
invasive procedure.
procedure
Any
or
Any
ankle
invasive
reduction.
procedure.
like sutures, like removal foreign body, drainage of abscess, any surgery in the ankle. Easy?
Easy, sir.
Yes, sir.
Okay. Fill the block.
Numb the
For
area.
numb the area of
Which area?
abscess. Abscess.
The abscess. To do
Incision
Drainage.
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 Incision and drainage of the abscess.
Incision and the drainage. Easy? Okay.
Easy.
Wound infiltration. What is the indication?
To numb the area of the wound.
Numb the area of the wound.
To do the suture or
Procedures.
the.
Clear?
Yes, sir.
Yes, sir.
You see, I'm giving you treasure now.
Yes.
Okay.
Lot of ticket.
Okay. So we finished the indication. I think I finished the indication of all nerve blocks inside the body. Okay. I will go for contraindication for all. Okay. What is the contraindication for nerve block? You can fix this one. It will help you in any nerve block.
Any allergies.
Allergy. Allergy. What else?
Infection at infiltration site.
Infection at the insertion site.
Infection, like cellulitis. Okay. What else?
Distorted landmarks.
Okay. So if the patient needs a general anesthesia, right?
Yes.
Easy?
Yes. Yes, sir.
Okay, because it's a local anesthesia. Any patient needs general anesthesia. I mean, for example, patient needs intubation. He has GCS less than 8 and he has wound in the face. You will do local anesthesia or general anesthesia?
General.
General, because he will be intubated, right?
Yes.
So any patient needs general anesthesia, don't do local anesthesia. Okay? Okay. So fix this approach. Allergy, infection, any patient needs a general anesthesia. For example, the patient has seizures. It means he needs sedation, right? Okay.
Yes, sir.
We will go for complication. Fix this complication for all. Number 1, infection. Number 2,
Toxicity.
bleeding.
Toxicity.
Number 3, the most important, don't forget, local anesthetic toxicity. Easy?
Yes.
You will fix this in all nerve blocks. We will go for how to avoid local anesthetic toxicity. How to avoid. After that, we will go for how to treat.
Okay.
Which seconds, guys? So, how to avoid? Fix this in all.
Yes.
Number 1, adequate, accurate dose calculation. Okay. Number 2, reduce doses in extremes of ages. I mean, very young or very old. Number 3, use ultrasound guidance. Easy now?
Yes, sir.
Okay.
Yes.
We will go for how to treat the complication. So if the patient has local anesthetic, and you should prepare intralipid. This is how to avoid. Okay. How to treat? Number 1, you will move the patient to monitor the area. Oxygen, fluids, intralipid if the patient collapse. Easy?
Yes.
Yes.
Fix this in all. So we finish the indications for all, contraindications for all, how to complication for all, how to avoid, how to treat for all. Okay?
Yes, sir.
Okay. Regarding the procedure itself, we will talk for each one. Okay? So regarding some complication or some contraindication. For example, birth block. Birth block, you can say if the patient has bilateral fracture, no need to do birth block. Or if the patient has high blood pressure, so don't do birth block. So I mean, I give you contraindication for all, but also you have some additional contraindication for some nerve blocks. Did you get my point?
Yes.
Okay.
Yes, sir.
Anyway, if you did not remember the specific contraindication for birth block and you mentioned the general contraindication, no problem. You can get 10 out of 10. Okay? Okay. So the procedure itself, you will cover, you will, you will clean the area, cover the area, expose the landmark, and then insert the lidocaine anesthesia. Maximum safe dose, you should mention. After that, you will wait for 5 minutes and then you will use the forceps to check numbness. Easy?
Yes.
This is this for all. Okay. So regarding the maximum safe dose. So for lidocaine, how much?
3 milligram
3
per kg.
milligram per kilogram.
Milligram. Excellent. 3,
7 is adrenaline.
so 3 milligram per kilogram. Regarding bupivacaine in the fascia iliaca and the fascia femoral nerve block, how much?
It is less than
2
2 mg, 2 mg, yes, 2 mg per kg.
2 milligram per kilogram. Okay. So lidocaine, how much?
3 milligram.
3
3
milligram,
milligrams per
Bupivacaine, how
kg.
much?
2
2
milligram,
milligram.
2 milligram.
3 multiply 2,
6.
6
6.
milligram. Brolocaine. Easy?
Yes.
So 3 lidocaine, bupivacaine 2, and multiply 3 by 2.
6. Excellent.
Right.
Are you happy, huh? Okay.
Yes.
Okay. So we will go for one by one. Yara,
Yes, sir.
okay. You will teach me about supraorbital and the Zishan.
Yes, sir.
How are you?
I'm fine, sir.
You will teach me infraorbital
Okay, sir.
and May.
Yes, doctor.
You will teach me mental,
Okay.
Shayati.
Yes, doctor.
You will teach me dental.
Okay.
And okay. Omar,
Yes, sir.
you will teach me ear. Okay.
Okay.
So I will give you all quickly. So for Yara, Zishan, May, Yara, Zishan, May, supraorbital, infraorbital, and mental. All of them the same line. It will be mid-pupillary line. Okay?
Please repeat, sir. Which line?
Mid-pupillary line. Can you see the pupil?
Yes.
Yes, sir.
Vertical line. Transecting the pupil. Easy?
Easy, sir.
So for supraorbital, the mid-pupillary line transecting the eyebrow. Here, this one.
Okay.
Okay. So when you are injecting for the purpose of the exam or for real practice, it's not about to insert here or here or here in this area. Clear? So
Yes, sir.
Yes, sir.
you will direct the needle from lateral to medial. Easy?
Yes.
It will be parallel to the eyebrow.
Eyebrow.
So you will insert from lateral to medial, which point mid-pupillary line transecting the eyebrow. Done. You will feel the foramen. Which foramen?
Supraorbital foramen.
Or
Okay. The direction from lateral to medial. What if the
Medial.
doctor asks you, what about supratrochlear? You will advance the needle like 1 to 2 centimeter and infiltrate. Done.
Mhm.
Okay.
Eh, Once you verbalize that, you will get 10 out of 10. He will not ask you to do. Okay? Okay. So what about infraorbital? The same. The shan. It will be
Mid-pupillary line,
irregular line.
infraorbital,
Excellent.
infraorbital margin,
Below
below the
Right,
lower
lower
eyelid.
eyelid by 2 centimeter.
Mhm.
Clear?
Yes, sir.
The direction, the
Lateral to
direction.
medial.
You have 3 direction. Zishan.
Yes, sir. I am listening.
Yes, you have 3 direction. Number
Okay.
1, perpendicular. Number 1,
Okay.
number 1,
Perpendicular.
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 Okay. Number 2, can you see the nerve? Like
Yes.
M shape.
Yes.
So, inferior, right?
Inferior.
Inferior. Okay. One of them lateral and one of them medial, right?
Yes, sir.
Both of them going down or going up?
Down.
Down.
Going down.
So, inferior, right?
Yes.
One of them lateral, one of them.
Medial.
Medial.
So you have to numb the one lateral and to numb the one medial. Clear? So you have 3 direction. Number 1,
Perpendicular,
perpendicular.
then the lateral and the medial.
So in number 2, inferior lateral. Number 3,
Inframedial.
easy?
Yes. Sir.
Easy.
Thank you. Thank
Okay.
you.
So
Thank you.
how to remember inferior? How to remember inferior? So we said infraorbital. Infra the same as inferior. Clear?
Yes.
Mhm.
Okay. I think you are happy now.
Yes, sir.
Very much.
Okay. So
That's reverse.
what about mental? May.
Upwards.
May.
W.
So M. So M,
Inverted M.
it means medial.
Oh, yes.
M mental, M medial, and the M may also.
yeah. Okay, we
Good job,
remember
sir.
it.
You remember it in the exam.
Yeah.
We will not forget it.
Okay. So number 1, perpendicular. Okay. Number 2, medial, superior, and the medial, inferior.
Inferior.
So this one is clear. So medial, you have 2 branches here. Both of them going to medial, right?
Yes.
So this one going to medial, this one going to medial, but this one superior, this one
Inferior.
Inferior.
Yeah.
easy.
Yes, it's clear. Okay.
Okay. So this one, because infra, it means inferior. And this one, mental, it means
Medial.
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 So this perpendicular and then inferior, medial, inferior, lateral. This one perpendicular and the medial, superior, medial,
Inferior.
inferior. Okay. Regarding Shayati,
Yes, sir.
you will go for dental. I will explain dental later. Okay.
Okay.
And also regarding Omar, I will explain ear later. So for you, the same indication and everything. You will divide the station into 3 parts. Okay, we will start by the first one, Yara.
Yes, sir.
Okay, you have 30 seconds and then 6 minutes. But the most important, after doing the procedure, you will wait for 5 minutes and check the numbness by forceps. Okay. The preparation here, as we mentioned, prepare the doctor. So wash hands with PPE. Preparation of the patient. The patient will be in
Yes.
sitting position or in lying position. Okay. Regarding preparation of equipment, you will mention, okay? Post procedure, you have to dispose
Okay.
equipment, document, do the suture or do the procedure, if suture or removal of foreign body or whatever, and then
Okay.
check if the patient for discharge or for admission. Okay,
Okay.
you have 30 seconds and 6 minutes.
Okay, can I start?
Okay, you can start.
Hello, I'm Dr. Yara Idris-Char. May I have your name and level, please? Nice to meet you. I heard you wanted to discuss a nerve block with me today. Okay, what do you know so far about this? Is there anything specific you'd like to learn? Okay, so I heard you have a patient and he needs a nerve block for a wound above his eyebrow. Is that right? Okay, let's go to the patient and we'll explain everything to him, and I'll explain everything to you in details later. Okay, hello, sir. May I have your name and age, please? Okay. I heard you have a wound above your eyebrow and it needs suturing. So I am here to give you a local anesthetic to help numb the area above your eyebrow
all
on the
nerve
same
block,
side.
all nerve block, you don't have patient.
You don't, so I'm just explaining? Okay.
Teaching.
Okay, so I'll tell you about the indications, the contraindications, complications, how to prevent them and how to treat them. And I'll explain the procedure and what we have to do after the procedure. So first, the indications for any nerve block in general is to numb the area. Here we're talking about the supraorbital nerve block, so we need to numb the ipsilateral area from the forehead or the scalp up to the upper eyelid. You can either just infiltrate the supraorbital nerve, or you can advance slightly and you can also numb the supratracheal nerve. So for a patient with a wound above the right eyebrow, we're going to infiltrate the supraorbital area. So the contraindications are if the patient requires general anesthesia, this is an absolute contraindication. And if he refuses, you have to give the patient alternatives if there's an infection at the site or if the patient is allergic to the local anesthetic. What are the complications that could happen? The patient could suffer from an infection due to lack of aseptic technique. There could be some bleeding, and the most important complication that we're worried about is local anesthetic toxicity. So how to prevent local anesthetic toxicity? We have to calculate adequate and appropriate doses for each patient, reduce the dose in extremes of ages. We use ultrasound guidance, and we have to monitor the patient. So what happens if the patient does suffer from local anesthetic toxicity? First, we'll move the patient to a monitored area, to a resuscitation area. We'll put the patient on oxygen and give fluids, monitor the patient. If the patient suffers from collapse or arrest, we have to give the patient intralipid. Okay, so now how do we do the procedure itself? First, the patient will be either in a supine or a lying position. I'll wash my hands, I'll wear my PPE. I'll prepare my equipment, an ultrasound for guidance, a nerve stimulator, iodine for cleaning the area itself, and our needle, 25 gauge needle for an adult and 30 gauge needle for a pediatric. And our maximum, we'll be using lidocaine. So our maximum dose will be 3 milligram per kg. And then we'll draw an imaginary line vertically through the mid-pupillary area, okay, to the angle of the mouth. So what we'll do is we'll clean the area with iodine, we'll drape the area, and then we'll approach the patient from a lateral direction, heading towards the mid-pupillary line, which bisects the eyebrow at the medial 1/3 and the lateral 2/3. We will inject our needle from a lateral to a medial position, parallel above the eyebrow, and we'll aspirate to check that we are not injuring any vessels. And then we'll slowly start injecting while while pulling the needle out. And then we'll wait for 5 minutes, check if the area is numb, and then we will move on with our procedure. So we'll keep the patient under observation for a while after that, and we will dispose of our sharps and clean and give the patient post-procedural advice that if they feel numbness or tingling in their body, if they feel any metallic taste, if they start getting dizzy, they should warn us, and we'll give them post-procedural advice for the suturing or whatever invasive procedure we do. So here, if the patient has a wound above his eyebrow, we'll ask him to keep the wound dry, and if he needs antibiotics, we'll check his immunization status, and to return 7 to 10 days later for suture removal. Is everything clear to you? Is there anything else you'd like me to explain? Do
Okay.
you have any further questions?
Okay, thank you, Yara. What do you think, guys? You still have 30 seconds. What do you think, guys? How many marks?
Okay.
10 out of 10.
Yes, 10.
Yes.
Excellent.
Yes.
Excellent performance.
Yes. So I think you did very well. You are teaching everything by a good way, and accuracy, I think you covered 100% of the approach. The checklist regarding skillfulness, you are very fluent, mashallah. Also, you're pausing, you are giving information in pieces, and you are doing it very well. Supportive, because you are explaining in pauses, pieces.
Yes.
Yes, well done.
Impeccable. Perfect.
So also you are checking understanding, you are inviting questions. So I think you are doing it very well. Safety also, you covered how to avoid, how to treat, and when to check. Yes, well done. So I will give you 10 marks, and I'm happy also. Thank you, Yara.
Thank you, sir.
Okay. Next one, Zishan.
Yes, sir.
Okay. So it will be the same idea, okay? Different,
Okay.
the landmark and
Yes.
the approach.
Thank you.
Direction.
Yes. Bismillah.
Yes.
Okay, my name is Dr. Zishan. I'm ED registrar. Okay, I am certain that you are here to learn the infraorbital procedure with me. So it's really a very common practice and a very common procedure here in the ER. So I'm happy that you have selected this procedure. So do you have any specific thing to learn? Okay. Do you know something about it before, earlier? Okay. Fine. That no problem. I will teach you. So we will have some this one objectives for you. We will start with the indication, and then we will I will tell you about the contraindication, complication, how to avoid the complication, how to treat in case if there is any complication. Understand? Then we will move towards the preparation for the equipment, for the patient, for the doctor. Then I will tell you briefly how to start the procedure, about the consent, and about the post-procedure and the documentation. So start with the indication is whenever you have to numb that area for suturing, for the foreign body removal, or some other procedure. Okay. In case of the contraindication, what is the contraindication? First of all, you will ask ample history. A for allergy, M for past prescribed medication, past allergies, and past history, past medical history, and the last meal and the event. You will take a brief history for the event, And then you will know about the allergies, you will know about these are the contraindication if there is any allergies in the ampelistry, any infection at the site like cellulitis. And in certain cases, patient need GA, like the patient is having the seizure or some other problem, you cannot give the local anesthesia, you have to GA. Understand? This is the contraindication. And the complication is infection or the bleeding may happen. Or you are giving the local anesthesia for the numbness. So it can cause toxicity if the dose is not appropriate. Understand? So you have to keep beside the antidote for it. Okay, how to avoid it is the adequate and the accurate dose. As you know, for the local anesthesia, 3 milligram per kg. Reduce the doses for the extreme of phases, like for the elderly and for the children. And the third thing is the ultrasound guided procedure. Whenever you don't know the landmark exactly, you can use it ultrasound guided, it will help you. And how to treat it? Prepare beforehand oxygen, keep the monitor beside it, and the antidote intralipid as I told you earlier. Got it? That's good. Now towards this preparation, simple. First of all, the position. Patient should be comfortable, either in the supine or in the sitting or the lying, wherever the position is comfortable. Most likely in the supine, it will be better. You will prepare sutures, lidocaine, suture on the face. This most likely we are using 504060. These are the thinner one, non-absorbent, which is called Proli. The patient, for the patient, you will just, and for the doctor, just wear the PPE and the wash hand proper. For this procedure, you will clean that area with antiseptic, and then you will drape that area, cover that area, only open that area, specific area, and then insert the lidocaine with the safe dose, which is 3 milligram per kg, you know earlier. Wait for 5 minutes, check the numbness with the forceps. Got it? And if the patient says, okay, he cannot feel any sensation, you may start the suturing, or you may, okay, whatever the requirement of that anesthesia, you will do it, either removal of the foreign body, suture, whatever. Okay. Then how to do the procedure? There are three. There is a landmark, mid-pupillary line, ipsilaterally, on the same side, it will numb it. Mid-pupillary line. Directions, there are three types of direction. One is the perpendicular, one is the inferior lateral, one is the inferior medial. In the mid-pupillary line, it will numb that same side, ipsilateral area, it will numb the whole area of this from the lower eyelid to the upper lid of the same side. So this is how you will do the procedure. And then you will go towards the post-procedure post-procedure instructions, like you will ask the patient for the tetanus, then immunization history. You can ask when the last dose of the tetanus was taken. So for the next 10 years, it is not required. So you can ask the patient either in that case, you may know you need to give it or not. You will give the leaflet, you will give the instruction to remove the suture. Usually on the face, you remove from between the 5 to 7 days. And then you will ask them to keep it dry for at least 48 hours. And then in case of the complication, this one advice and bleeding, pain, pus, if the suture breaks sometime, it become open. So come back to the ER. So these are the instructions. You understand? It is very simple procedure. Next time, whenever you have this case, you can do it comfortably. I will give you the leaflet, give you the website, and if you need my help in case of any patient in the ER, please call me. And the last thing is the documentation, which is very important. Write everything. What have you done? What have you explained? Thank you, sir. Thank you.
Okay. How many marks will give the Shan guys?
20 out of 10.
10 out of 10. But here I am confused, sir. He mentioned the sutures in this block.
Excellent, excellent. Okay, so what is your task, Zishan? Your task nerve block or suturing?
Yes, nerve block.
So why you talk about okay.
It is late night.
Okay.
Full of
So take care.
Stones and sand.
Take care. If you are doing teaching, don't give too much information. For example, can I do all sessions in one session?
no, never.
I will give you all the course in one session.
No.
For me, no problem. I can, but you will not understand. Okay, so don't teach two sessions or two topics together. So your knowledge appreciated, but for the purpose of the exam, it will decrease your mark. Clear?
Right, sir. Totally agree with you.
Yes. So don't show the examiner that you are much knowledgeable. Don't give him much information. Okay.
Okay.
Yes. Just focus on the most important points. So if the topic is 15 points and you mention the 15 points by concise way, you will get 10 out of 10.
Right.
Okay. So anyway, you did well. I will ignore so I will ignore additional information. I will give you 10 out of 10. Okay?
Thank you, Doctor, for your mercifulness.
Yeah.
Shukran. Thank you.
Okay. So the most important, guys, teaching. Number one, your tone should be normal, not fast, not too slow. So the actor or I mean the nurse or junior doctor or patient should understand. Number two, pieces of information. Number three, give the most important information and the most relevant also. Okay. Give the basics. Don't give advanced information. Okay. So for example, if you are teaching ECG, start by basics. Okay. Next time you can advance the information. For example, when I am teaching you today, not the same as in introduction, right? It's different because now you are trying to accept advanced information, right? Yes.
Yes.
Yes, sir. Yes, sir.
Okay, well done. So the most important here about because maybe the patient will do infraorbital, not for sutures, maybe for draining drainage abscess, or maybe for removal of foreign body. Okay, why I will talk about suture? No need. Okay, well done. Thank you.
Thank you, sir.
Welcome. May?
Yes.
Okay. So May M. Okay.
Yeah.
You have 30 seconds and then 6 minutes.
Okay.
Better when you are talking about nerve block, guys, you should mention the nerve course, the nerve course. So, for example, supraorbital for Yara, you should mention this branch of ophthalmic nerve, branch of trigeminal nerve. Infraorbital, you should mention it's a branch from maxillary nerve from trigeminal nerve. And the mental branch from my
Mandibular.
mandibular. Okay.
Mandibular from the trigeminal.
Yes.
Okay.
So you should mention from inferoalveolar.
Okay.
So mental from inferoalveolar inside the mouse and from mandibular outside the mouse. Clear now?
Okay.
And then from trigeminal. So 1, 2, 3, 4.
Mm-hmm.
Okay. So you have 30 seconds and 6 minutes.
Okay. Hello. Good morning. I'm Dr. May. Can you confirm your name and level, please? Okay. Thank you. Nice to meet you. I believe we have something to discuss today about nerve block. That's right. Okay. This is really interesting topic in an important topic in here. So how much do you know so far about nerve block? Do you have any specific point you want to focus? Okay, okay. So today I will teach you about how to block the mental. Okay, and later I will give you websites and videos to learn you more about this. Okay, you can feel free and to ask me and stop me at any point if you got confused or you don't understand. Okay, for this we have today I will divide this discussion to three parts. We have the pre-procedure, during procedure and post-procedure. For the pre-procedure, it's contain about indication, contraindication, complication, and how to avoid and treat the complication. Okay, for the indication, indication is to numb the area that we want to do the procedure on. Okay, the contraindication, if we have like allergy, the patient have allergy from the anesthetic we want to use, or there is infection at the site of procedure, or the patient needs general anesthesia. Okay, for the complication, it could be infection, it could be bleeding, it could be which is so common, the toxicity from the overdose from the anesthetic material. Okay, how to prevent this kind of complications? We have to do this under aseptic condition. We have to check the viability of the anesthetic material, and we have to use under ultrasound guidance. Okay, what we will do in case there is complication, how to treat with it. First of all, we have to stop the procedure. Okay, we have to move the patient directly to monitoring area. Okay, connect the monitor and give oxygen, give the patient fluid. Okay, and follow the ABCD approach at that time. Okay, so Dr. Are you following with me so far? Okay, any question? Okay, good. So now we have to now we came to during procedure. We have during procedure, we have the preparation. We have to prepare the patient. Sit the patient either sitting or lying flat. Okay, and we have to set our equipment. Okay, we need needle, 25 gauge needle. We have our anesthetic material like lidocaine. Okay, and we have to check the dose. It could the dose will be maximum 3 mg per kg for lidocaine. Okay, after that we have to use the aseptic material like chlorhexidine. Okay, and then we have to do the procedure, start our procedure. Okay, to assist this area, to numb this area, we have to clean it first. Okay, and then we have to inject the needle first perpendicular here in the. We have to draw a imaginary line in the mid-pupillary line. Okay, in the ipsilateral side. Okay, and then we have to inject our needle here in the mandible area, in the chin area. Okay, you have to inject the needle and then go perpendicular first, and then go to the medial to superior like this, if you can see here, and then you will infiltrate to inferior part. Okay, then you have to wait like 5 minutes until until the material the anesthetic take time to start to work. Okay, after 5 minutes you can start your procedure, suturing, whatever you want to do in this area. Okay, after that we have the post-op. procedure. Post-op, it's include you have to check a patient vitally stable. Okay, you have to dispose all your equipment. Okay, and also give patient advice regarding the suture or procedure done to him at that area. Okay, and then you have to document all your procedure with that. Okay, are you following so far, doctor? Okay, any question? Okay. As I mentioned, it's really interesting topic. Let's recap. Okay, we have a patient. We need to do mental. We need to do a mental nerve block. Okay, is this a branch from an inferior or inferior nerve? It's come from a mandibular nerve. It come from a trigeminal nerve. Okay, as I said, we block
Thank
this
you.
area.
Your time done.
Okay.
Okay. How many marks, guys?
10 marks.
10 marks, sir.
Yes, okay. Nothing about suturing? Okay.
No need.
So, I think you are covering almost all the points. Also, skillful, you're fluent regarding supportiveness, information in pieces, and you are pausing, you are checking understanding. Regarding structure, you are organized. Safety, you mentioned all the points of how to decrease or avoid and how to treat, and also indication, contraindication mentioned already, and you mentioned about the technique. Okay, so I think you covered almost everything. So 10 marks. Thank you.
Thank you, doctor. Dr. Hani, I want to ask you some question. We can do this procedure from inside the mouth?
Yes, this is called extraoral.
Uh-huh.
Okay, so it's not expected to ask you intraoral.
Okay. Okay.
Yes. So in the exams, you want you to do the easiest procedure. Okay. For example, in ultrasound, if you will use by ultrasound, um, ultrasound, yes, easier, but they will ask you what if there is no ultrasound? Not because of that, because not all hospitals they have ultrasound in ER. Okay. This is the
Okay.
point. But here regarding extraoral, it's easier than intraoral. Okay.
Okay.
Shayat,
Okay.
welcome. Shayati?
Yes, Dr. Hani.
Yes. We will go for inside the mouse.
Yes.
So it will be dental. Yes, this one. So as we mentioned, mandibular giving infraalveolar, and then go out again through the mandible to be mental, right?
Yes.
Okay. For you, so it will be the same. To numb the area, which area inside the mouse, okay?
Yes.
To do any procedure in the same side of the mandible, like removal of any teeth, or fixing teeth, or removal of foreign body, or drain abscess. Clear? Okay.
Yes.
So contraindication the same,
Yes.
complication the same, and
Yes.
how to avoid the complication the same. So what about the procedure? So
But we cannot do ultrasound inside. We will not say ultrasound.
no, it's not logic to use ultrasound here. Okay.
Yes.
And also, how we will do some
Yes.
palpating the chronoid notch. Easy.
Yes.
So of course you have to wear gloves. You have to emphasize on that because inside the mouse. So some palpating the chronoid notch, and try to be away from the teeth, because maybe the patient will close his mouse. Okay.
Yes.
If he close his mouse and your thumb by this way, it's away. Okay.
Mm.
So you will be thumb palpating the coronoid notch. Easy. Number one.
Yes.
Number two, you will numb the area. How to numb the area? Not by the needle. No. Numb the area and clean the area by normal saline. Clean first by normal saline the angle of the mouse. Okay. After cleaning by normal saline, you will put lidocaine gel.
Okay.
So you will wait for like 1 minute to be numb. Then when you insert the needle, he will not feel the needle. Easy?
Yes.
Okay. You will insert the needle, the direction will be from contralateral. So this one, the same side, it's called ipsilateral. The other side, it's contralateral, right?
Mhm.
You will
Yes.
put the needle where above or between first and the second premolar. Easy?
Between first and second premolar.
First
Okay.
premolar and the second premolar. Easy?
Yes.
So you will put the syringe and the
Yes.
needle 3 ml or 5 ml above the premolar first and the second.
Above premolar first, between first and second.
Yes, above the premolar between first and second. Okay?
Okay.
Contralateral. Okay. Then you will inject the lidocaine over how many minutes?
1 minute.
1 minute here. Can you see the mouse?
Yes. Yes, 1 minute.
Over 1 minute. So you will inject slowly. Okay?
Hmm.
Then here you can mention the landmark. It will be between the last upper and lower molar teeth. Easy?
Last, upper and lower molar teeth.
Done. Okay. You will wait for 5 minutes. You will check numbness. How to check numbness?
By the forceps.
Forceps. So you will check the shin, right?
Yes.
Why shin? Because this branch,
Mental learning command.
this branch is coming from where?
From the mandibular and then to the mental foramen it will come out. So
Yeah.
you will see
So
the number for the chin.
if the patient is not feeling the shin, it means all the mandibular branch numb. Clear?
Yes.
Okay. So here you are numbing the proximal part. If the distal part already numb, it means successful. Easy?
Yes.
Okay. So you have 30 seconds and 6 minutes. Omar?
Yes, sir.
Yes. Your station, it will be very easy. So here, same indication to numb the area. Which area? Around the ear and inside the ear. Clear?
Yes, sir.
And regarding contraindications, the same.
Yes,
Complications,
sir.
the same. How to avoid and treat complications, the same. And then the technique. You will inject lidocaine, maximum 30 milligram. It will be 1 point below the ear, 1 point above the ear. Easy?
Sorry, sir. 1 point below.
1 point below the ear, 1 point above the ear. Okay? So you will direct posterior 3 to 5 ml and infiltrate, and then you will direct anterior 3 to 5 ml and then infiltrate. Easy?
Yes, sir.
Okay. Above the same, infiltrate direct the needle posterior 3 to 5 ml and direct the needle anterior from this point 3 to 5 ml. So the degree of injection will be 45 degree or 30 degree. Clear?
Yes, sir.
Okay. So just mention the nerves. So above you are numbing which nerve?
Auriculotemporal.
Auriculotemporal means between the ear auricle and the temporal. Easy?
Yes, sir.
Okay. And down you are blocking lesser occipital and the greater auricular nerve. Okay?
Yes, sir.
You can take a screenshot. Give me seconds, guys. Okay, you can start.
Okay. Hello, I'm Dr. Chaiti, Emergency Registrar. May I know your name and level, please? Nice to meet you. I believe you have something to discuss with me. Okay. You want to learn about dental nerve. Okay. It's a fantastic topic and important skill. How much do you know so far? Anything specific you want to learn? Okay, no worries. I will set a learning objective. I will tell you the indication, contraindication, complication, and how to prevent the complication. Then the technique of the procedure and post-procedure, what is the advice to the patient? If there is any complication for the procedure, how to prevent it. And then or after that, how to document the procedure and advice to the patient. While the session, if you have any question, feel free to ask me. You can stop me at any time. Now let's start. What is the indication? So first of all, the dental nerve is basically a branch of, it's an inferior alveolar, which is a branch of the mandibular nerve. So we are numbing the dental nerve. So what is the indication? To numb the area inside the mouth. So to do a procedure pain-free, like if you are extracting a tooth or you are draining an abscess. What is the contraindication? If there is an infection at that site of insertion, or if the patient is allergic to local anesthesia, or the patient is refusing, or the procedure needs to be done under general anesthesia, that are the contraindications. Complications are the patient can have their bleeding, or there could be a local anesthesia toxicity. Now, how do we prevent the local anesthesia toxicity or the other complication? By doing an aseptic technique, number one. Number two is we do an accurate dosing of the local anesthesia and reducing the dosing of in extremes of ages, like in elderly and in children. So now, in case if the patient develops any toxicity from the local anesthesia, we should immediately stop the procedure, shift the patient to the monitored room, start him on oxygen, give him IV fluid, and keep intralipid in case the patient collapse or arrest. Am I clear till this point? If you have any question, please feel free to ask. Now let's go to the procedure. Procedure, first we have to prepare the procedure. How do we prepare our procedures? Like first we have to prepare ourselves, wearing our personal protective equipments, then taking lignocaine, local anesthesia, sterile gauge, 25 gauge needle, and then we have to specify the landmark. We have to explain the procedure to the patient, take a consent from the patient. Then patient, we have to make the patient, mostly in the dental procedures, are in the sitting position, in a comfortable sitting position. So we have prepared the equipment. Now we will select the landmark. How do we select the landmark? We will take with our thumb, left thumb, we will palpate the coronoid notch. But be careful to be away from the teeth of the patient. Okay. And this area is between the last upper and the lower molar. Now what we will do, we will clean that area with the normal saline. After that, we will take a lidocaine gel for 1 minute. We will keep it. After cleaning that with lidocaine, putting the lidocaine gel to numb the area. After that, we will withdraw around 3 ml of lidocaine by 25 days later. We will go from the contralateral side. How we will go? We will contralaterally, we will inject above the premolar, between the first and second premolar, and we will inject 3 ml local anesthesia slowly over 1 minute. Then we will wait for next 5 minutes. After 5 minutes, we will check the numbness by the forceps over the chin, because the mental nerve is the other branch through the mandibular's other branch, the mental nerve. So if we feel there is a numbness around the chin, that means we have successfully anesthetized the patient. After the patient confirms that she is feeling numbness when we are touching by the forceps, we can proceed with the procedure, whether it's an extraction of a tooth or an incision drainage or whatever the procedure is. Post-procedure, we need to keep the patient, and if you have keeping the procedure after the patient is comfortable and ready to discharge, we have to document all the events, dispose our equipments in the respective bins, and then advise the patient in case of any complication or any opioidal numbness or any complication, patient should come back to ER. Am I clear till this point? If you have any doubt, you can please ask me, or we can again recapitulate the process which I have taught you now.
Okay.
So we can.
Thank you, Shayat. You still have 1 minute. So what do you think, guys? How many marks?
Very organized. Excellent.
Organized. 10 by 10.
Yes. Even she finished within 5 minutes, but she is not rushing in time, right?
Yes.
Yes.
So accuracy, almost mention 100% of the approach. Skillfulness, 100% fluent. Regarding supportiveness, she is supportive. She is giving information pieces, checking understanding. Even she is trying to recap in the end. I think she is doing very well, organized, and a safe doctor also. So 10 out of 10. Thank you.
Thank you very much.
Well done. Okay, the last session for today. Amr?
Yes, sir.
Okay. So teach the junior doctor or junior nurse about ear nerve block. So I think now you understand the general approach, so you are ready for any nerve block, right?
Yes, Rakan.
Yes. Okay.
Alhamdulillah.
Alhamdulillah. Okay, so you have 30 seconds and 6 minutes.
Okay. Hello, my name is Dr. Farooq. I am one of the ED senior. Can I take your name and level, please? Okay. Thank you. I believe that you want to learn about the nerve block around the ear. Okay. Thank you. Okay. So may I know how much do you know about it? Okay. Okay. Thank you. Is there anything you want to know specific? Okay. So let set our learning objects. So today I will teach you the indication of the nerve block and contraindication, also the complication, and also the how to avoid the complication, and by any chance if there are any complication, what we can do. And also we'll be teaching that the before the procedure and what to do in the procedure and after the procedure. Okay, shall we start? Okay, thank you. And at any point, if you got any question, please let me know. Okay. So the indication is that we have to if we need to numb a defined area like in the ear, so we have to give the local anesthesia. And the contraindication is that if they, by any chance the patient has any allergy to the drug, and also is the any infection on the side, or any if the patient need any general anesthesia, so in that case we can't do that. and there are some complications like infection, bleeding, or toxicity. And so how we avoid the complication? The main thing is that we have to calculate the accurate dose, which is for local anesthesia lidocaine 3 milligram per kg. And also we have to reduce the dose like in old age and very early age. And also we need to do with the ultrasonography guidance. Okay, am I clear to you? Okay. So how to treat complication by any chance, if there are any complication? So we have to move the patient first of all in monitor area, and we have to give oxygen, IV fluids, and also if by any chance any collapse, then we can give the antidote like interlipid. Okay, so let's prepare our thing before the procedure. So we have to before preparation, we have to talk to the patient. We need to take the ample history, and also if there any injury, we need to take the immunization history, and also we need to check the vitals, and also we need to examine the patient, and we need to take the consent. After that, we have to prepare our instrument, like we need a needle for our anesthesia, like 25 gauze, and we have to take the lidocaine 3 milligram per kg, and we have to clean our area like the ER, and then we have to give the local anesthesia and wait for 5 minutes and check for after 5 minutes check there any numbing by using forceps. So what will be our landmark? So am I clear to you so far? Okay. Do you have any question? Okay. Thank you. Okay. So we can numb the area by around the ear or also inside the ear. So there is 1 point below the ear and 1 point above the ear. So the direction in the both side will be posterior and anterior. You have to infiltrate like 3 to 5 ml of local anesthesia. Okay. And how which nerve are there? So there are, as you know, that there are 3 nerves. Above the ear there is the auriculotemporal nerve, and below the ear there is lesser occipital and also the great auricular nerve. So by giving this anesthesia, we can numb 3 nerves around the ear. Okay, so when you get that after 5 minutes, there is numbness, we can start our procedure. And after the procedure, we have to make a documentation of every steps, and we have to give the advice to the patient. We can give some printed leaflets, and we can monitor the patient. Okay, so do you have any question? Okay, so if you got any question, please let me know. And if you want to learn any other things, please let me know. I'll be more than happy to teach you. Okay, thank you.
Okay, thank you, Omar. You still have 1 minute 40 seconds. How many marks, guys, you will give, Omar?
10, sir.
Okay.
Mashallah.
Okay. So I think now it's very easy about nerve block, right?
Yes, sir.
Okay. So what I need from you, prepare for the next decision. We will finish all nerve block tomorrow, okay?
Okay.
So
Inshallah.
do you have any problem if we will do tomorrow? It will be 4 p.m. UK time.
No
No
problem, sir.
No
problem.
problem, sir.
Yes,
Okay, sir.
no problem.
So
Can do every day.
we will finish nerve block, and we will finish teaching ECG, ABG, and bold elbow and the other points. Okay.
Okay.
So
Okay.
we still have examination. The next decision will be after tomorrow. Will be joint and system examination. We can make 2 sessions in break, like 2 hours break. Clear? No problem?
No problem, sir.
No problem. Yes, doctor, no problem.
Okay, so tomorrow again, 4 p.m. we will make 1 session to finish all teaching. Then after tomorrow we have 2 sessions after tomorrow, we have how many sessions?
2.
2. 1 for joint, and then we will take break like 2 hours, and 1 for system examination. So we still have only communication. Clear?
Yes, sir.
Yes.
Are you happy now?
Yes, sir.
More than
Thank you,
thank you.
sir. Thank you so much.
So we will try to make much mock exams, inshallah.
Inshallah.
Thank you, guys, and bye-bye.
Thank you, sir. Thank you.
Thank you, sir. Take care. Shabbat.
Thank you, sir.